Hello, my name is Anna Hetmansberger, and I'm currently a student at Eastern Kentucky University, where I'm pursuing a degree in their Rural Health Family Nurse Practitioner program. At the beginning of NSC890 nursing research, we were challenged to identify a healthcare problem that was of interest to us. Working in a neurointensive care unit, I chose to explore aspiration pneumonia among stroke patients with dysphagia because I've noticed that this is a prevalent problem among this patient population. In fact, aspiration pneumonia is the second most common infection among hospitalized patients. It also has the highest attributable mortality of all medical complications following stroke and is responsible for over 200,000 cases and 15,000 deaths in the U.S. alone. The incidence of developing aspiration pneumonia triples among adult hospitalized stroke patients after discharge, and rehospitalizations due to aspiration pneumonia are costly, potentially harmful, and often avoidable. So what exactly is aspiration pneumonia? Aspiration pneumonia refers to a lower respiratory tract infection caused primarily by the inhalation of oropharyngeal secretions that are colonized with pathogenic bacteria. This can also be caused by the inhalation of food and liquids. You can see how this could be a problem for patients with dysphagia. During my literature review, I came across 4 studies that addressed aspiration pneumonia among stroke patients with dysphagia using non-pharmacological interventions. The first study by Teray and Marin looked at the effectiveness of the chin-down posture to prevent tracheal aspiration. The study found that 55% of patients avoided aspiration when using the chin-down posture. The second study by Lamb, McMillan, Samaranaki, Lee, McGrath, performed in 2013, evaluated the effectiveness of oral health promotion intervention on clinical health and the development of infectious complications such as aspiration pneumonia. This study looked at 3 different interventions, one being oral hygiene instruction, the second group being oral hygiene instruction plus chlorhexidine rinse use, and the third group being oral hygiene instruction plus chlorhexidine rinse use and assisted brushing. The study found that oral health was greatly improved throughout all intervention groups, and no cases of aspiration pneumonia were observed in any of the participants. The third study, reviewed by Jethani, Van Ness, McGlowan, Argrave, Shin, Charpentier, and Quadrilario in 2015, sought to determine if a multi-component intervention protocol, including manual tooth gum brushing plus chlorhexidine use twice per day, as well as the patient being in the upright position, could reduce the incidence of developing aspiration pneumonia among nursing home patients. The study found that a multi-component intervention protocol did not significantly reduce the incidence of the first radiographically confirmed pneumonia or lower respiratory tract infections compared with usual care in nursing home patients. The last study, reviewed by Yakichuk, Bertone, Giabi, Brown, Liarkos, and Brothwell in 2003, sought to determine whether a suction toothbrush reduces the incidence of aspiration pneumonia in dependent adults with dysphagia. The study showed that daily mouth care improved, as well as reduced pneumonia rates in the adult patients with dysphagia in the nursing home. Synthesis of the data reveals that non-pharmacological interventions, such as using the chin-down posture when swallowing, as well as oral health promotions such as manual brushing and chlorhexidine use, suction toothbrushes, manual brush, and maintaining an upright position during meals may reduce the incidence of aspiration pneumonia. My proposed intervention to address this clinical problem and hopefully change this area of nursing practice would be to implement an interdisciplinary transitional dysphagia education program that would be nurse-driven. The intervention would focus on educating patients and their families on multiple non-pharmacological interventions that would be performed outside of the acute care setting and basically at home. The education program would begin on admission to the acute care setting and continue until the patient was discharged. At that time, the patient and their family caregiver would be followed up with on a weekly basis by the transition nurse for the first 30 days after discharge. Because the act of swallowing is very complex, the interdisciplinary team would consist of the primary care provider as well as ancillary departments, such as case management, dietary, occupational therapy, and speech therapy. Having an interdisciplinary approach would also provide more exposure and support for the patient and their family or caregivers. That is the end of this presentation, and I would like to thank everybody for their time and hope that you have a wonderful day. Thank you.